Okay, we're going to talk about the cysts of the jaws, right? And of course, of the soft tissues also. Basically, cysts of the jaws have been there for a long time, and there are many classifications, right? Before we proceed for the lecture, I would request you to keep your own video and audio off. You can ask the question through the chat box at the end of it, and I'll be very happy to answer. Okay. So what is the definition? The definition of a cyst, since you're 5 years, you ought to know it because in the 3rd year, you already had it actually. So cyst is a pathologic cavity or a sac which has fluid, semi-fluid or gaseous content and which is not created by the accumulation of the pus. Most cysts, but not all, are lined by epithelium. This was given by Kramer in the year 1974. Now, the classification has repeatedly undergone a lot of changes. Other people.
Oh.
So the cysts of the jaws are classified into epithelial and non-epithelial. Then the epithelial ones are, which would be laying stress on basically, are the developmental ones and the inflammatory. And then within the developmental, you've got odontogenic and non-odontogenic. The inflammatory ones are definitely the odontogenic, the example of which is the radicular cyst, right? So the next one is again the epithelial cysts can be classified into the gingival, the developmental odontogenic cyst, gingival cyst of infants, odontogenic keratocyst, dentigerous cyst, eruption cyst, so on and so forth, right? The ones which we are going to be dealing with and the ones which are most common are the dentigerous cyst, odontogenic, the odontogenic keratocyst, and of course in the inflammatory type we are going to talk about the radicular cyst, right? Which is the inflammatory type. This is the radicular cyst, and once you extract a tooth and unfortunately pathology gets left behind, then you have a residual cyst which is present there. The non-epithelial line cysts are the solitary bone cyst or the aneurysmal bone cyst, right? The solitary bone cyst is nothing but it's a developmental defect, okay? Now, when we talk about the cysts with the maxillary antrum, you have the mucocele, the retention cyst, the pseudocyst, and the post-operative maxillary cyst. Now, the mucocele can happen because of a surgical procedure also, which you are aware as called, which is called as the surgical ciliated cyst. When there is trauma, you try to get the maxilla back into position and the epithelium gets entrapped. Or in those cases where you have an orthognathic surgery and you reposition the maxilla superiorly, there's a chance that it can get entrapped. Okay. The cysts of the soft tissues of the mouth, face, and neck are also innumerable. So you've got dermoid cyst, lymphoepithelial cyst, thyroglossal cyst, cystic hygroma, nasopharyngeal cyst, and the cysts of the salivary gland, the mucous extravasation, and the mucus retention cyst, right? So these are some things that we will be talking about, okay? The frequency of cysts, the most common one is the radicular cyst, and for a good reason, right? And it's usually seen more in males because the most common site for a radicular cyst to happen is the central incisors, and males are more prone for trauma, right? Because of road traffic accidents or interpersonal violence, right? And then the tooth gets devitalized, leading to a cyst formation in the periapex. The next one is the dentigerous cyst. The third one is the odontogenic keratocyst, right? And then you have all the other cysts which are a minority as compared to these three cysts, okay? So we need to know clinically and theoretically about uh, the radicular cyst, the dentator cyst, and the odontogenic keratocyst, and you are much aware of what happens actually. The cyst initiation is something which is very interesting. The exact stimulus is not known, right? In inflammatory odontogenic keratocyst, infection is considered to be as a precipitating factor, right? In some individuals, cyst forms from developing odontogenic epithelium, that is the dental lamina, the enamel organ, extension of basal cell, the reduced enamel epithelium, and the cell rest of Malacus, which we are going to see in the subsequent slides. Okay. So if you look at the clinico-radiologic presentation, right, this is the odontogenic keratocyst, right, which can occur usually on the lateral aspect, or it can completely encircle the tooth, okay, which may give a false impression of a dentigerous cyst, right. This is the basic histopathology which we are not going to deal with, but you ought to know, you should not forget it, right. And this, in this particular radiograph, you may not be able to visualize it much, but then usually you can see a nice hollowed out effect, okay, in the radiograph. The most important thing about a keratocyst is the fact that it can grow in an anterior-posterior direction, right, because it spreads through the pathway of least resistance. So it goes through the medullary cavity, right, and this leads to the formation of a cyst, which is there, which may not be possible for the patient also to realize, and it usually is seen in an incidental radiograph. Okay. Then you have the dentigerous cyst, which comes from the reduced enamel epithelium, right, or the tooth follicle, and this is the usual presentation which you see over here. I don't know how these lines appear actually. It's a mystery how these lines keep appearing. I've seen them in other presentations also, so I'm sorry for this, right? Then you have the lateral periodontal cyst, okay, which appears in the between the cyst, between the tooth and the bone, okay. The radicular cyst, which comes at the periapex, okay, that is one of the most common things, right? Inflammatory odontogenic cyst. Then you got the eruption cyst, which is seen in young children, something like this, okay. And the gingival cyst. Now, these are certain things which may not merit an active surgical intervention. However, you ought to know it. Because of the paucity of just the 40 minutes of time, we are not going to deal with every possible cyst, but basic treatment of cyst and representative cyst, that is OKC, dentator cyst, and the radicular cyst. Okay. So these were certain representative things. How does the cyst form, right? So you have a small granuloma which is there. Okay, this is for the radicular cyst. Then this granuloma keeps expanding. Okay. Then what happens is, in the center part, it undergoes necrosis. Apart from that, there is hydrostatic pressure because, as you know, because of osmosis, there is fluid which moves from a lower gradient, sorry, from a higher gradient to a lower gradient. So you have the cyst which grows, and once you have the influx of the ions over here, it further keeps growing, right, till such time that it attains the size of a huge cyst. Okay, so this is what the cyst basically forms. Okay, so you have water as the major part, right, and this leads to formation of the cyst. Okay, is there somebody is working on the I don't know why these lines keep appearing. Anyway, for diagnosis, history is very important. When you ask the patient whether there was some trauma, right, whether the patient met with an accident, you have to locally examine it. There could be a missing tooth, which will give a clue to the fact that there could be a dentigerous cyst which is forming, right? Then in investigation, the usual baseline investigations, imaging, and then you have the histopathologic examination after you have removed the cyst. Okay. So the treatment modalities are curettage, enucleation, radical enucleation, marsupialization, and resection. We would be basically dealing now, unfortunately, this is not in a very particular order, but marsupialization is something that we start with. Okay. Then we go to enucleation and curettage. Okay. Now, when you are talking about curettage, curare means to scrape. Okay. These two terms, curettage and enucleation, cannot be used interchangeably. Enucleation is just removal of the cyst lining. Curettage is to ensure that there is no tissue that is left behind in the bone, right? What happens with odontogenic keratocyst is the fact that, you know, there are, you have something which is known as the daughter cyst, a high mitotic activity, the thin fragile lining of the radicular cyst. Now, this particular thing leads to the cyst recurring, odontogenic cyst that keeps recurring. Okay. So, you have to be very sure about the treatment modalities that happen, right? So marsupialization, which is known as Parshvan operation, okay? So in their viva, you could be asked, or in a question, there could be a short answer question which says Parsh 1. So Parsh 1 is nothing but marsupialization, okay? So marsupialization or decompression refers to creating a surgical window in the wall of the cyst and evacuation of the cystic contents. The surgical part I'll just show you in a moment, right? What are the indications? In a young child with developing tooth buds, you cannot go in for an extensive surgery such as enucleation. So what you do is you just open the roof of the cyst, make it continuous with the oral cavity so that the cyst content comes out, the cyst lining goes down, it becomes smaller, and then you can remove the cyst lining after that. Otherwise, what happens is if you go for a radical treatment like enucleation, you're going to end up with something like, damaging the permanent teeth buds. In elderly patients who may not be able to tolerate an extensive surgery, marsupialization is a less stressful and reasonable alternative. And if there is proximity to vital structures, which are the two important structures in the orofacial region? The first is the maxillary antrum, and the second one is the inferior dental nerve, right? The IANB. Okay, so it's very important that we protect them, and marsupialization is one technique by which we can do it. Okay, so this helps in eruption of the teeth. In very large cysts where enucleation may result in pathologic fracture, you know that, if there is a large cyst and you try to enucleate it, the bone is obviously going to be weak and then it's going to fracture. Of course, there are ways of overcoming it, which is more of a PG topic. But anyway, I'll just let you know that if at all enucleation has to be done, you have to do a prophylactic plating. Okay, I'm sure you know what is plating. You have to do a prophylactic plating so that along with bone grafting, right? So this is how you achieve it. Okay. So now this is the basic procedure for enucleation. You create a small window, right? Remove the bone if it is there. Okay. Part of the cystic lining is removed. Okay. And then you suture it. You suture the remaining cyst to the oral cavity and put a pack inside. Now what happens? When you keep a pack inside and you keep inspecting the patient every 48 hours, in such a case, it will be easy for you to visualize it, clean it, and make sure that the size has got reduced so that ultimately you can go in for enucleation at the later stage. What is the disadvantage of marsupialization? Is the fact that you leave some pathologic tissue behind, okay? So, which is not needed. So that is why you do something called as marsupialization, okay? So that is the advantage of marsupialization. The disadvantage is you leave pathologic tissue behind, okay? Then after that, there is a modification of marsupialization, which is called as Waldron's technique. This is what I talked about, okay? So when you are sure that you have reduced, you got the cyst lining that is reduced, in that you proceed with the enucleation, that is marsupialization followed by enucleation. That is also called as Waldron's procedure. The advantage is that, when there is a little bit of cystic tissue left behind under observation, it becomes slightly thick. So that makes enucleation easier. It spares the adjacent tissue structures, right? It reduces the morbidity in the sense of, if you do an enucleation, there is a chance of a pathologic fracture or infection which could happen. The disadvantage is that there is a secondary surgery that is done, right? Now you cannot escape it because you cannot leave any pathology behind. So that is a disadvantage of the Waldron's procedure. Okay. Now we come to enucleation. Now this is also known as the Parch 2 procedure. It allows for the cystic cavity to be covered by mucoperiosteal flap, and the space fills the blood clot, which may eventually organize and form a new bone. So when you have an accessible cyst, such as a radicular cyst, I'll show you the image. Okay. In such a case, you have to enucleate it, right? Oops. Okay. You have to enucleate. When you enucleate it, you have to make sure that you are removing everything. You can put a bone graft over there, or you can put PRF, right? And that will lead to a good secondary bone healing formation, and it will be very beneficial for the patient, right? The post-operative care is reduced. In the present scenario, you could be asked a question in your viva that in the times of Corona, would you do a marsupialization? I would not do it, because you have to recall the patient time and again. Okay, so which is not a good thing. So in such a case, if the patient is, can withstand the surgery, go ahead and do it. So this is a cyst which you see here, right? And you can see it over here also. So what is done is you enucleate it, give a mucoperiosteal incision, open the cyst lining, right? There are different patients, okay? They're not the same patient. So this is in the maxilla, this is in the mandible, right? And then you put a graft there and suture it primarily, okay? Now, the developmental odontogenic cysts, we've talked about the treatment part. Now we'll just go through just rush through it. OKC was introduced by Philipson, right? And it has been renamed and re-renamed. So it went to KCOT, and now it has been classified again as odontogenic keratocyst, okay? So these are seen in the third, fourth decade. There's a predilection for males, right? It may occur in the upper and lower jaws. However, it is seen in the ramus and the third molar region primarily, more than the anterior mandible, right? And many a times it is totally asymptomatic. The patient is not aware that it exists, okay? Now, the recurrence rate is very high. We know why it is high. I gave you a reason, because of the thin lining, the daughter cyst or the satellite cyst, and the fact that it is very friable, okay, and got a high mitotic activity, okay. So the pathogenesis is from the dental lamina, right? The basal cell, the enamel organ. So this is basically what it looks like. This is the primordial type. This is the dentigerous type, which we talked about earlier, which will encircle the whole tooth and mimic what is known as the dentigerous cyst, right? So there could be paresthesia, right? The buccal expansion of the bone is seen, okay? At times, not always. It may be unilocular. Now you see here, it's a big unilocular radiolucency, which is marked in yellow, right? In the yellow arrows, okay? It can attain huge size from ramus to ramus of the opposite side, right? This is again what you see over there. Now, basically, when you're dealing with an OKC, you have to be slightly aggressive, okay? And you have to do an enucleation in such cases, right? When you aspirate in an OKC, you will get something cheesy material which is there. right? This is pathognomic of a OKC, right? You can do chemical cauterization with carnoy solution, okay? When we are talking about dentigerous cyst, before you go for actual enucleation or marsupialization, you have to aspirate it. And when you aspirate, like I said, for OKC, you'll get a cheesy material. For dentigerous cyst or a radicular cyst, you may get a straw-colored liquid, right? Then it can be subjected either for microscopy, okay? And then when you subject a radicular cyst for microscopy, you see cholesterol clefts, okay? Now, it is basically seen in those patients who have got supernumerary teeth or teeth which are erupting late, like the canine or like the mandibular third molar. So these are the usual sites where you can see it, okay? It is more common than OKC, if you remember the previous slides, right? And then there's a decline because the highest incidence is found in the second and third decade, okay? There's a slight male predilection of 3:2. The site is the mandible, and however, you can see it also in the upper cuspid region, that is the maxillary canine and bicuspid region, okay? So the clinical features is hollowing of the ramus. Usually the mandibular third molar is the most frequently impacted tooth, and that leads to this particular issue, okay? So there is expansion of the cortical plate. It causes a hard, painless swelling. And when you compress it, if you are aware of ameloblastoma, when you get that classical eggshell crackling, it is possible that you could get it with this. So what you see here in yellow, in the blue arrows, is an impacted cuspid with which is displaced and seen in the maxillary antrum, right? And then you have to make sure that you enucleate it, okay? The problem with the dentigerous cyst is that it can cause ameloblastoma if it is not treated in time, okay? So there are radiologic variant. This is the most common one, the one which you see on the extreme left, the central type, right? And then you got the circumferential type also, okay? So treatment is marsupialization or enucleation, which is indicated marsupialization in in younger children. This is the case report which you see over here, a painless swelling in the palate, right? There's an impacted tooth. We open it, right? Ensure that the maxillary lining is intact, and this is what you get, the cuspid tooth along with a huge cystic lining, right? And then you close it primarily, okay? Now we come to the last part, that is the inflammatory origin, which is the radicular cyst, okay? Now this is basically, it arises from the cell rest of Malassez, right? This is if you see the radiologic images, there is a radiolucency which is seen in the periapex. The tooth would be non-vital, right? Majority of the cases are asymptomatic. If you look at because we are trained to look into teeth, we will definitely see a tooth that is discolored, especially the anterior tooth. And then we can always suspect, if it's a long-standing case, we can always suspect that this patient has got a radicular cyst or a periapical granuloma, right? So there is expansion and all is not very much, right? There could be a sinus tract because it is an infected thing, right? It's an inflammatory infectious process. So you have to ensure that you do a vitality test and then do a root canal treatment, right? What you see in this particular image on the lower left side is the cholesterol clefts, right? This is the CT images of a patient and can attain huge sizes. If you see this CT, there is a erosion of the palatal bone, right? So the treatment is you have to do a enucleation, do a root canal, do an enucleation, right? This is the specimen, right? Put a PRF and close it primarily, right? So this is something that you need to deal with, right? And sometimes, of course, If it's a granuloma, it can resolve with root canal treatment. Otherwise, you have to go and do a curettage by raising a flap, right? So I think I'm running out of time. So this is the other case. Okay. So what we learned here today is basically the three types of cysts, which are very important, and the way we have to deal with it. If it's a large cyst, go for marsupialization. If it's a smaller cyst, we have to go for enucleation. Now, this is what is the sequelae? Enlargement of size, infection, malalignment, pathologic fractures, which is very much possible. In conclusion, the decision is based on clinical and radiologic presentation. Aggressive enucleation of the cyst is the workhorse. Even after you do marsupialization, when you do the Waldron's procedure, you have to go for enucleation. Use of Carnoy solution can be used selectively, right? And in times, you can use liquid nitrogen because that can cause what is known as cryotherapy. But then the workhorse is the enucleation. The room for resection is very limited. It's only for recurrent odontogenic keratosis, right? And I thank you for your patience.